Good morning, everyone. It gives me immense pleasure to introduce today's speaker, Dr. Subodh BN. His, his academic qualifications are he has done MD in psychiatry. He's an alumni of PGI. He has also done postgraduate diploma in medical law and ethics. He is a professor of psychiatry as well as my senior colleague at Drug De-Addiction and Treatment Center. He has around 130 publications in the area of substance use disorder, mood disorders, and consultation liaison psychiatry. Of more so particular interest is the area of dual diagnosis, which is the intersection of substance use as well as severe mental illnesses. I request my co-chairperson, Dr. Abhishek Ghosh, to introduce the topic.
Thank you. Thank you, Dr. Shalini. It's a very pleasant duty to introduce the topic. Dr. Subodh is going to talk on comorbid substance use. How does it influence the presentation and management of first episode psychosis? In the last presentation, Dr. Rubaksh has nicely pointed out and elaborated on the first episode psychosis in general and what are the possible causes of treatment resistance. Perhaps this is one of the causes that, at least if not resistant, but one of the challenges that you as a clinician might have faced during your practice. Dr. Subodh will delve into that. Dr. Subodh perhaps will also talk about whether the use of substance can actually have causal influence on psychosis. Does it actually influence the course and outcome? Does it influence the presentation in general? What types of substances are usually associated with psychotic symptoms? We know cannabis, but what else? Are there any changes over the years? Because we know that there has been an increase in the potency of cannabis across the world. So are there any change in the incidence of psychosis in general? So kind of, it's a very fascinating and engaging topic, and Dr. Subodh is a very good speaker. So I would request Dr. Subodh to kind of deliver his lecture. Thank you.
Good afternoon, everybody. In next 30 minutes or 30 to 40 minutes, I will be talking about how comorbid substance use influence the presentation and management of first episode psychosis. The outline of my presentation will be, first I will be briefly talking about why we have to understand there is a, if there is a relation, what kind of relation between substance use and first episode psychosis, and what is the extent of the problem. I will be talking about the Western literature, Indian studies, and limitation of the studies and the trends which has been currently there from the literature. And in the presentation proper, I will be talking about only the consistent findings. There are some findings which I may not be talking because they are not consistently reported in the literature. In the presentation, I am not talking about particularly cannabis-induced, alcohol-induced or something like that. But if at all, if some literature is there, I will be talking particularly on that. Otherwise, it will be a common overview rather than on a specific substance and the psychosis part. Next, I will be talking about briefly the assessment management. What is the difference in the classificator system on the diagnosis and evidence-based management for first episode psychosis with substance use. Already been talked about the first episode psychosis and whether substance use or disorders has been reported in first episode psychosis. For this, emphatic answer is yes. And if at all substance use or disorders are reported in first episode psychosis, they have poor prognosis, they have high disability, they have more chance of having more severe psychotic symptoms, they are having chances of more medical problems, they are high chance of having higher number of hospitalization, which all these factors will lead to complicate the course of illness in the form of having recurrent episodes, prolong the duration of illness of first episode psychosis, treatment dropouts, and more disability, which also leads to increase in the homelessness. What has also been seen in the literature that if you manage substance use in first episode psychosis, their outcome is similar to those who do not use substance in first episode psychosis. Basically means if you manage properly the substance use in first episode psychosis, their outcome is similar to having only the first episode psychosis, not the substance use, and they don't have whatever the features I talked about, the complicated course of illness, and other disabilities. Now coming to the extent of problems, we have the substance use in first episode psychosis has been talked in terms of current use and the lifetime use. You can see that the prevalence range is more common in alcohol, cannabis and tobacco. This is basically because there are more literature on this compared to other substances like stimulants, cocaine, opioid and other substances. So the range is from 0.5 up to 80%. So all these ranges, why there is difference in the range? This is basically because of the methodological difference in the studies, particularly how they are defined the current use or the lifetime use of substance, or whether they are diagnosed as a substance use disorder in the form of dependence, harmful use, abuse or other terms, and also the definition of psychosis as such, whether this only they are talking about psychotic symptoms or psychotic disorders, or if they have reported only symptoms, what kind of symptoms they are talking about. Next, coming to the diagnostic method used, if structured instruments are used, then the prevalence comes down, and if checklist and less rigor measures are used, the prevalence goes higher. And also the setting wise, if the research is done in special setup, particularly the first episode psychosis setup or the integrated setup, the prevalence is higher compared to the psychiatry setup and substance use setup. It's basically because they will go to the special centers in the Western countries compared to they are coming to the general setup. Now coming to the Indian studies, as like every subject, there are sparse literature. I can find two studies particularly talked about substance use in first episode psychosis, one from south and one from northern part of India. And the one study used the structured instrument for the diagnosis and other used only the clinical interview methods. So the numbers is one had 139, another was 79 first episode cases. What we can see that the nicotine is the most common substance used, followed by alcohol and cannabis. In one of the substance used was in Bangalore study, they had one inhalant user. In the northern part, they didn't have any other substance apart from these. There is also reported cannabis, like 1 in 5 cases, they had dependence in the first episode psychosis. Now coming to what is the trend in the Western literature, which is when we talk about substance use and the first episode psychosis. Here the young adults we are talking about in the age range of 18 to 25. What we can see that there is high prevalence of substance use in first episode psychosis in young adults because they have tried or used cannabis, alcohol or tobacco at some point in their lifetime. But when you talk about the current use, this is slightly higher than the general population. The range is around 24 to 61, particularly of cannabis, alcohol and tobacco. This particularly the setup entry to the first episode psychosis treatment. Okay, so the current use, the prevalence is less, but the most important and significant finding from whatever literature we have is lifetime use of alcohol and cannabis use disorders are fairly common. This is double the rate which is there in the general population. It means that if there is lifetime use of alcohol and cannabis use disorders, the prognosis and other factors we have to look in the first episode psychosis. As I already told, there are less studies on cocaine, opioid, other stimulants and hallucinogens, and the rate is less compared to alcohol, cannabis or tobacco. Now, after briefly talking about what is the extent of problems, I will just briefly talk about what is the different presentations we get when we have substance use and first episode psychosis. The majority of the studies are on cannabis and psychosis, and few studies are on other substances, alcohol, tobacco, cocaine and others. The design used in majority of the studies are cross-sectional, and the prospective cohort studies and the longitudinal epidemiological studies have given some insight into particularly the relation between cannabis and psychosis. when we talk about substance-induced psychosis, there are three important findings in the presentation. If they have visual hallucinations, if they have diagnosis of dependence on any drug, or if they have family history of parental substance use, the odds of developing substance-induced disorders is high in first episode psychosis. The diagnosis of dependence, the odds is around 10 compared to others like visual hallucination, they're 2 times compared to any other psychopathology. And compared to others, like if the first episode psychosis, those who have used drugs, and first episode psychosis who are not taking any substances. There are other parameters which are giving some insights like age of onset of psychosis. In substance users, the age of onset is 2 years earlier compared to those who do not use substance in first episode psychosis. Other important factors are if they have substance use in first episode psychosis, there will be more hostility, violence, thought disorders, behavioral problems, and the severity of depression, mania, and anxiety symptoms are more if they have substance use disorders in the first episode psychosis. Another important finding in the presentations are the duration of untreated psychosis. If the person has first episode psychosis and if the person is currently using cannabis, the duration of untreated psychosis is shorter compared to he is using once in the lifetime or long time back. And this is opposite in alcohol use disorders. The duration of untreated psychosis is longer in alcohol not used when they are taking alcohol in the large quantity compared to small quantity. In cannabis, if they are current users, the duration of untreated psychosis is shorter. For alcohol, it is the large quantity of alcohol, not once or twice or occasional use of alcohol, which is making increasing the duration of untreated psychosis. Now, another important finding is in substance use disorders with first episode psychosis, there doubles the risk of poor adherence to any pharmacological treatment. Now coming particularly to the cannabis and psychosis, these are the findings from the cohort studies and the longitudinal epidemiological studies, which has clearly showed that if there is a lifetime cannabis use, then the chance of developing psychosis is approximately 2.4 to 6 times controlling the solvent use disorders and the parental separation. And there is a direct dose response relationship in terms of if they are using cannabis more than 50 times in their lifetime, there is high chance of developing the psychosis with cannabis and developing later into schizophrenia or whatever on the long term course. And there are others important findings as cannabis use increase the risk of developing psychosis in the range from 1 to odds ratio of 1 to 3% depending on controlling for several factors, which is approximately 6 factors, which some important are the other substance use, personality traits, and intellectual ability. Another important findings in these epidemiological studies is that if there is consistent cannabis use, the psychotic symptoms also increase in severity. And another important finding is the possibility of reverse causality, which I will be talking in the next slide. It basically means that cannabis use is a consequences rather than the cause of the psychosis. It basically self-medication hypothesis. Those who have developed the psychosis, they use cannabis to improve their negative and depressive symptoms rather than cannabis is causing the psychotic symptoms. And recent studies found this finding more consistently after adjusting several other factors also. After these findings has to be understood by understanding also the limitations of the studies which have been consistently reported, like there is some sample bias, and if it is cohort studies, the cohort effect, the period and time of exposure to the substance, the duration of exposure to the substance is not being defined in majority of these studies. Exposure to multiple drugs is also they report, but they are not talking about the extent of exposure to multiple drugs, whether they are severity is also there to other substance use. There are several other unknown factors like personality, stresses, and others also not been talked about. Definition of psychotic symptoms to psychotic disorders also gives some whatever we have to interpret this finding, we have to keep all these factors in and then interpret the findings, whatever I have talked about. Now briefly coming to the overview on assessment and management. Uh, the assessment has to start as early as whenever they come to the treatment setup. The psychotic symptoms, if at all there, then the onset of symptoms, symptomatology, the duration of untreated psychosis. There are other factors like already talked about, the family history of substance use or psychotic symptoms, or family history of any mental health disorders. In substance use, particularly the number of substances, if they are using polysubstance or only use, dependence and other factors, the duration of substance use, if they are abstinent from substance, the consequence of substance use disorders, treatment to substance use and the response, and chronic and persisting symptoms are there. If the person has stopped the substance, what is the course of the symptoms, and also the interrelation between the symptoms and the substance use, and other things like other psychiatric and physical comorbidity, if at all, then has to be established and then made a diagnosis of. In treatment history, response to previous medication trials, compliance, side effects, etc. also has to be looked into. Thorough mental status examination, physical examination is a must in all the cases. Particularly if you are starting off antipsychotic, then you have to know the waist circumference, body, BMI, etc. And investigation, first thing is to confirm the diagnosis of substance use using urine screen. Other routine tests, particularly if you are adding antipsychotic, then the fasting blood sugar, lipid profile, ECG to look into QTC and interval, because there is interactions, some drugs increase the QTC interval, so we have to be careful about. And clinical diagnosis in both children and adults using multiple source from family members, available informant, clinical diagnosis, and the diagnosis has to be made as per criteria set up in ICD-10 or 11 or DSM-5. Where after making the diagnosis, we can use the structured scales to confirm the diagnosis, and also sometimes if you want to use the extent of substance use or the severity of psychotic, specific instrument also can be used. While talking about the management, it has to be comprehensive and multi-pronged care, continuous and prolonged integrated biopsychosocial approach to care. What Urvash has already talked about, what is being proposed by the NIMH group, the SAMHSA group particularly, they are talking about the multi-pronged and involving different professionals in the care of first episode psychosis. And in India particularly, we have to have an active collaboration with the family members, because family members are our strength compared to the Western countries. And management has to be sensitive to the need and empirically based on the literature. Though throughout the either screening, diagnosis or planning treatment and referral, we have to have a rapport with the patient and always talk about substance use and motivating the person to think about his substance use and how it is contributing in worsening or causing poor prognosis in the management proper. After briefly talking about assessment, I will be talking about the diagnostic status of in current diagnostic systems. So diagnosis of psychosis, substance use disorder is well established and there have been set down criteria, but there is some significant difference between DSM-5 and ICD-10 in the definition of substance-induced psychotic disorders. In DSM-5, they basically tell mere presence of psychotic symptoms in conjunction with recent exposure, that is exposure defined as during or within 1 month to an used substance is adequate. But in ICD-10 and 11, they talk about severity of such psychotic symptoms must be clearly in excess of what may be expected from intoxication or withdrawal, unlike DSM-5, from the dose of the substance to which the individual was exposed. This is the ICD-10 criteria where it is common to all substance-induced psychosis or organic-induced mental disorders. So there has to be evidence-based, there has to be a temporal relationship and recovery after stopping of whatever the substance, in particular substance in psychosis, and absence of evidence to suggest an alternative cause of mental disorders. In ICD-11, the same thing, what I already talked about, the symptoms should develop during or soon after intoxication with or withdrawal from the substance, and symptoms has to be substantially in excess of commonly seen in withdrawal and intoxication, and the amount and duration of substance use must be capable of producing the psychotic symptoms. Compared to DSM-5, which the disorder developed within 1 month of substance intoxication or withdrawal, the involved substance or medication is capable of producing the mental disorder like in ICD-11, and the disorder is not better explained by any independent mental disorders. Other things like they should not be during the course of delirium and other things. Now coming to the evidence base of management if they have first episode psychosis and substance use, what is the evidence talks about. For this, the SAMHSA group has provided the evidence base in the form of strong evidence, moderate evidence, limited evidence, and no evidence of effectiveness. Here, when they talk about strong evidence, they are talking about effectiveness demonstrated in systemic reviews or meta-analysis of RCTs. Moderate effect, when they talk about effectiveness demonstrated in at least 2 RCTs, judged to be sufficient methodological quality. Limited evidence if at least one RCT or 2 matched control groups or meta-analysis with a significant methodological problems. And no evidence and not demonstrated the effectiveness is not demonstrated in any study, regardless of the study design. This meta-analysis published in 2019 Schizophrenia Bulletin, which had approximately 19 RCTs and had 1,742 participants. The most frequent types of substance use were cannabis and cocaine. In this, they include all cases of schizophrenia from first episode psychosis to chronic schizophrenia. So this 19 RCTs what we are talking about include all chronic schizophrenia, diagnosed schizophrenia, first episodes, and those who have only first episode psychosis also. Here the primary outcome was reduction in substance use. The secondary outcomes were craving, mean reduction of substance use, overall change in schizophrenia symptoms and negative symptoms, response, dropouts, quality of life, social functioning, weight gain, sedation, and other side effects of the medication. This was a negative meta-analysis where they are shown that firm conclusion cannot be drawn from this meta-analysis, but they have also mentioned that clozapine, olanzapine, and risperidone has shown some superiority compared to any other antipsychotic in decreasing the substance use. But this finding of whatever is from 2 RCTs where the sample was not very high, one was around 31 and one was 40. Overall, this meta-analysis had several limitations. One is insufficient reporting of the outcomes they are talking about, and the small sample size in majority of the studies. The largest sample they had was around 150 around. And majority of them was around starting from 12, around 30, 40 or 50. This study is not for first episode psychosis. One study among all these 19 RCTs was in first episode psychosis. That study showed that there is no difference in substance use, particularly alcohol and cannabis, in first episode psychosis cases on risperidone or olanzapine. That is why the SAMHSA group, the evidence base they are talking about, there is no evidence base, particularly of pharmacological interventions decreasing the substance use in first episode psychosis. Now coming to the non-pharmacological treatment, which is along with the routine treatment, that is particularly pharmacological and other education, awareness, and family group intervention in cases done in first episode psychosis. There are 2 important non-pharmacological interventions majority of the studies talk about is the brief motivation enhancement or skills training and cognitive behavior therapy plus motivational interviewing. In brief motivational enhancement or skill training, here they are talking about they are helping the individuals overcome ambivalence about substance use or not to use, and develop skills need to reduce or stop substance use. There are two RCTs which have significantly showed that substance use after the intervention there is decrease in substance use than the treatment as usual. But the limitation is first one study has small sample size of 35 and another study had good number, but the difference no longer significant after 12 months of follow-up. This second study has concluded that this brief motivation enhancement as skill training, the booster dose has to be done after 6 or 9 months so that the effect lasts longer. The other therapy which has done in particularly in first episode psychosis with substance use is cognitive behavior therapy and motivation interviewing. Here they are helping the person who has substance use in first episode psychosis development of the shared formulation of substance use problems and the psychotic symptom, psychoeducation about the relation between substance use and psychosis, goal setting, change planning, coping skill training and motivation enhancement. There were 5 RCTs which have shown that it is not effective than a comparison treatment, where the comparison treatment was including psychoeducation or time related intervention in cases who have first episode psychosis and substance use. One small RCT of 4 to 6 session has shown that treatment group experienced significant decrease in the frequency of cannabis and alcohol. There is one which had good number also to show that this finding is significant, but majority of 5 studies have were the negative studies. Because of this, the SAMHSA group told that both these non-pharmacological intervention have low evidence base because they have one had 2 RCTs, one had 1 RCTs. Now coming to other outcome parameters like functional outcomes, particularly in non-pharmacological studies, they have studied this, the decrease in the number of symptoms, severity of the symptoms, or decrease in the number of hospitalization, and the functional outcomes in the form of quality of life, improved functioning and other parameters. Both these therapies don't have any evidence base. In the they are RCT studies, but they are not shown any findings. With this, I will conclude my presentation, which I have 5 points I will highlight. Basically, that lifetime substance use common among first episodes psychosis, which is compared to the normal population is double the rate, and consistent finding have been reported in presentation, particularly if they have visual hallucination and family history of substance use and diagnosis of dependence. The chances of substance induced psychosis is higher, and if they have first episode psychosis with substance use, more violence and physical behavioral problems are more compared to those who do not have the substance use. Substance use treatment should play an integral role in first episode psychosis because it is one of the factors which is making a poor prognosis and to have long-term illness and sufferings. Research needs to be done to build an evidence base for intervention because not much literature is on that. Everyone talks about in reviews and individual experiences when they talk about they give, but when you scientifically assess the effectiveness, the evidence base is very less. And there are few limitations which I have already highlighted in the what is the extent of problem, presentations and management also, and future studies should work on this. These are my bibliography. Thank you. I want to thank my senior resident, Dr. Nidhi, who has helped me in preparing this slide. Thank you.
Thank you, sir, for the comprehensive presentation. You have extensively covered right from the extent of problems, the diagnostic guidelines that we have on also the evaluation and evidence-based management in the overlapping area of substance use and first episode psychosis. I invite audience for questions, clarifications and comments. Yeah.
Good morning, sir. Sir, 2 questions. First is, various authors use different terminologies like cannabis or substance induced versus precipitated versus unmasking of psychosis. So, could you clarify that? I mean, how are these terms different? And Second one is what is the evidence for and against concurrent versus sequential treatment of the substance use disorder and the psychosis?
Okay. I will take the second question first. That is the easier one, because now the whatever the evidence, like I have not talked about that, when they are concurrently managing both substance use and the episodes of psychosis, the prognosis is better according several literature, and it has to be intensive treatment. It cannot be like just educate about substance use or educate about the psychotic symptoms and they have to take the treatment and all those things. You have to address others, like their day-to-day difficulties, particularly if they are young adults and adolescents, because of if if you don't handle those things, there are chances of you continuing using substance use and worsening their episode of psychosis more, and prolonged treatment will be there. And the US group, particularly U group also, they are talking about the integrated treatment, not the first you treat, first sequential treatment or not. It is always integrated, which has found to be effective, but as already highlighted by Urvaksh, these are all costly interventions, and manpower and dedicated team has to be there to manage that. And regarding your first question, it is whether cannabis induce or cannabis has brought forward the psychosis. That was your question, or what was it? All they are interchangeably used depending on their own fantasies or whatever they think about it.
Is there also a prize for the number of questions? I don't think so, right? Yeah, there is a prize only for the best question. So yeah. So please give others some chance to ask questions.
Sir, you are not eligible for the contest, but you can ask questions.
Jokes apart, yeah. Yeah, no, no, very, very practical presentation, important. I was just wondering, because your presentation says, rightly so, that there is a substantive prevalence of or proportion of people with substance use disorders, right? This directly contrasts with what Dr. Tara has been saying since yesterday and today also in the Madras longitudinal cohort study, that one of the stark things was that it was only 4 to 5%, much lower. So I was just wondering, so obviously they are two contradictory. So what might be the reason? One obvious reason is that it could be what we call a secular effect, not a time cohort effect. At that time it was not there when they started. Or could be a geographical effect, could be something else. Because the Prabhat Chand study, the Bangalore Nimhan study shows about 20%, if I'm not mistaken.
Yes.
I'm just rattling
Dependence
off
20%, around 40 to
so any comments on that? Because that's and also the types of, because again the meta-analysis system you have shown is cocaine features, but in India at least, as we so far we know that cocaine is not there. So both the percentage, comment on the percentage and the types of substance. Thank you.
Yes, that basically Dr. Tara was talking about study which was done in 70s when she first started the follow-up of those. So it may be because at that time the substance use not to extent, but the recent 2013 and 2018, where they are reported that it is around 20% had dependence in the first episode psychosis. That method used, whatever in Bangalore one, they used the structured instrument. So it is basically because of the time gap, because most probably because of that. And Indian, actually when we are growing, the magnitude of substance use also increasing. The earlier the magnitude of substance was less, and gradually over the years the substance use problems and the prevalence is increasing. And because of that, the prevalence is also increasing. The Western, it is already high, because when I talked about the 4 points I was talking about, the current use was slightly higher than the normal population of cases. In particular, that whatever I was talking about, majority of the findings are from US and few studies from Europe. The current use was slightly higher than the normal population, but the lifetime use was double, and in some studies more than 3 times. The lifetime use In USA is around 12 to 18, approximately 20. The findings in both the studies, like there are several studies, is around 40 to 50% they have there. So it is more than double the lifestyle use, substance use. So if we want to, like India current prevalence of substance is around 20 to 30%, and that is corroborating with the evidence from the India, the Bangalore and the North Indian study. And the North India, what we can see is that the cannabis was there, but the alcohol was equivalent to tobacco in terms of dependence.
From anyone? It's almost the lunch time. So, yeah. So I would like to thank Dr. Subodh for a very clinically relevant presentation, and I hope that you have gathered clinical knowledge, wisdom, and you'll be able to manage your patients with first episode psychosis and substance use disorder better after listening to this presentation. You would know that where to look for. If you would like to know some evidence, then Dr. Subodh has talked about that Substance Use and Mental Health Administration of the US. That is one of the data sources. EMCDDA publishes, has a very good data source. So these are the data sources you can look on. Thank you very much. So again.
Thank you, sir. I would now like to request the chairpersons to felicitate the speaker. I would now like to request Professor R.K. Lennon, sir, to please felicitate our chairpersons. Thank you, sir. We will now be taking a break for the lunch. I would request you all to join us in the foyer area for lunch. The session at 2. Sharp 2.